Okay, guys, so let's discuss the next topic that is about the types of calcification. So, first of all, what is calcification? When there is the calcium deposition in our body, that is called calcification. And when this calcium is going to deposit it in our body, the tissue will looks like basophilic. So basically this basophilic is mainly because of calcium. When on the tissue the calcium is going to be deposited, that tissue will look basophilic on hematoxylin and eosin stain. So this is the staining method which is used to see the tissues which has a deposition of calcium. So then after that we have the two type of calcification. One is dystrophic and the second one is metastatic calcification. So first of all, you guys have to remember the basic difference between the dystrophic and metastatic. So let's take an example. This is the dystrophic calcification, and on the right side we have the metastatic calcification. You just have to remember two things. First of all, we have to understand the serum calcium level. What is the level of serum calcium in both these conditions? In the dystrophic calcification, the calcium is going to be normal in your blood. It means the serum calcium is normal, but the tissue which is going, the tissue in which the calcium is going to be deposited, that is the abnormal. So here the serum calcium is normal, but the tissue in which the calcium is going to be deposited, that is abnormal. And this abnormal tissue will try to, you can say, will try to call the calcium. The calcium will come and deposit on that abnormal tissue. This type of calcification is called dystrophic. Then after that we have the metastatic calcification. In metastatic calcification, your blood calcium is going to be increased, and your blood calcium is more, but the calcium which is going to deposit it on the tissue, those tissues are normal, those tissues are not diseased. So this is the basic difference between the dystrophic and the metastatic. So let's take a quick review from the first aid. They say the calcium is going to deposit it and on the tissue, and that tissue is abnormal, that tissue disease in the dystrophic calcification, and it tend to be localized. It like here they mention the example of calcific aortic stenosis, like the calcium is going to specifically deposit in the aorta, and then that can lead to the aortic stenosis, and that aortic stenosis is because of calcium. This is called calcific aortic stenosis. Then what are the conditions that are associated with dystrophic calcification? Like if a person has the TB, in the TB you get the calcification of lung and the pericardium. Then other granulomatous conditions. Then in the liquefative necrosis of chronic abscesses, fat necrosis, infarction, thrombus, cystomiasis, congenital cytomegalovirus, toxoplasmosis, rubella, Psammoma bodies, Crus syndrome. Then we have the atherosclerotic plaques. Then all these are the conditions which are associated with dystrophic calcification. And atherosclerotic plaques can also become calcified because these plaques will again attract the calcium. So these are the associated conditions. Then what is the etiology? So basically due to injury or necrosis, your let's suppose if your tissue is going to be injured, that injured tissue will again will, you can say, catch the calcium. When that injured tissue will catch the calcium is going to deposit it. So this is the etiology. Then after that we have the metastatic calcification. Basically in this the calcium is going to deposit in the normal tissue. Your serum calcium is more, but the tissues are normal. And again in this the tissue is going, the calcium is going to be deposited in widespread fashion, in diffuse fashion. That is not specific, that is not localized. So please keep this in mind. In the metastatic calcification, the calcification is going to be widespread. It involves the multiple systems, it involves the multiple tissues. Then what are the associated conditions? Like predominantly the calcium is going to be deposited in the interstitial tissues of kidney, in lung, gastric mucosa, because these you can say tissues loses acid quickly. So the tissues which loses acid quickly, their pH is going to increase, and when the pH is going to increase, that increased pH will favor the calcium deposition. So they can ask from you in exam, why in the interstitial of kidney, why in the lung, why in the gastric mucosa calcium is deposited more? So the reason is these tissues will love to lose the acid quickly. When acid is losing quickly, it's mean the pH is going to be increased. the pH is going to increase, it will favor the calcium deposition. Then after that, you guys have to remember one thing, when the calcium is going to deposit in the collecting duct of your kidney, it is called nephrocalcinosis. And when you get the calcium deposits in the collecting duct, your ADH is not going to work in the kidney. So when the ADH is not going to work in the kidney, that will lead to nephrogenic diabetes insipidus. That is not central, that is nephrogenic, because it is a problem in the kidney. Then after that, it can also lead to renal failure, because when the calcium is going to deposit in the collecting ducts, your collecting duct will not function normally, so it will lead to renal failure. So these are the associated conditions. Then after, in which condition you will get the metastatic calcification, like if the person has CKD. In the CKD, what will happen? In the CKD, your phosphate is going to be accumulated in your blood. So when more phosphate in the blood, your calcium is going to less. So when the calcium is going to less, the PTH is going to produce in more. When the PTH will produce more in your body, the calcium is going to be more. It will lead to hypercalcemia. So that's why they mention here the example of CKD. In the CKD, it will lead to hyperphosphatemia, and the hyperphosphatemia will lead to secondary hyperparathyroidism. That secondary hyperparathyroidism will lead to secondary hypercalcemia. Then after that, the hypercalcemia from other causes, like if the person has primary hyperparathyroidism, if the person has parathyroid adenoma, hyperplasia, or the tumor of parathyroid. So if the parathyroid tumor is present in your body, that tumor is going to produce more PTH. The more PTH will lead to the more calcium, that will lead to hypercalcemia. Then we have the sarcoidosis. In the sarcoidosis, we also know that there is large amount of production of calcium. Then hypervitamin D, if you take the vitamin D more, that will lead to increased amount of calcium in your body. So these are the examples, or these are the causes in which you get the metastatic calcification.